In terms of specific examples of the accountability core element, the first is identifying a single clinician leader or two clinician leaders who will be responsible for sepsis program management and outcomes. The next is setting ambitious but achievable goals for improving sepsis care and outcomes that are informed by review of the hospital practices, the hospital sepsis outcomes, and updated clinical practice guidelines. Ideally, these goals should be specific, measurable, achievable, relevant, and time-bounded. The next priority example is assessing progress towards the hospital sepsis goals at regular intervals, such as annually, and updating those goals periodically to promote continual improvement in the hospital. The next example is identifying a physician or nurse leader or champion at each hospital. And this is for hospitals where the sepsis program may be organized at a health system level, such that the clinician leader or co-leaders are for the entire health system. In those types of situations, it's important that there always be a physician and nurse champion within each hospital. Next slide, please. Additional examples of accountability include having sepsis program-related activities and outcomes in the annual performance reviews for sepsis program leaders, identifying unit-level physician and nurse champions, and then reporting the sepsis program activities and outcomes to senior leadership and/or the hospital board on a regular basis. Next slide, please. I'll now talk to the multi-professional expertise core element. Sepsis is a disease that can occur to any patients throughout the hospital, and so it's really important that the hospital sepsis program includes a broad stakeholder group. Priority examples to demonstrate multi-professional expertise include having a sepsis coordinator who is in charge of day-to-day implementation of hospital sepsis program activities. Collaboration across key hospital locations, such as the emergency department, the hospital wards, and the intensive care units. The next is engagement of multi-professional expertise, including nursing, emergency medicine, critical care, hospital medicine, and other primary hospital services, such as infectious disease, pharmacy, and social services. The next core element speaks to engaging hospital antibiotic stewardship program to ensure that antibiotic recommendations for sepsis are tailored to local data, and include discontinuing of antibiotics once they are no longer indicated or needed. The final priority core element is engagement of relevant support services, including individuals with expertise in quality improvement, implementation science, information technology, and analytics. Next slide. The additional example of multi-professional expertise is having ad hoc domain expertise. This would be individuals who may not need to be at every single meeting of the hospital sepsis program, but can provide relevant input on an as-needed basis. This includes individuals working in case management, microbiology, phlebotomy, outpatient clinics, hospital epidemiology, infection prevention, and then patients, families, caregivers, and community members.
I'm going to be speaking on the things we did at Henry Ford Jackson as we developed our sepsis program. I'm hoping that this especially helps folks at hospitals who are just starting on their sepsis journey or are kind of new to it. Next slide. Oh, no, you're at the right slide. Sorry. These are the key points I'm going to talk to you about today. Organizational structure of our program, engagement of key partners, specific roles and expectations of our leaders, goal setting, monitoring progress, revising goals, and then some of our challenges and successes. So first, organizational structure of our sepsis program. We have a dyad leadership structure of a physician champion who is an ED physician and a sepsis coordinator who's a nurse. The physician has certain time dedicated to sepsis, and the coordinator position is a full-time position dedicated to sepsis. This slide shows our steering committee, our sepsis steering committee, and that includes an executive sponsor, nursing leaders, physician leads from the ICU, ED, and the floors. And we also included our physician residents. This committee functions as a steering committee and it drives care throughout our hospital. The members set the goals every year, they review the data and ensure compliance. They make the protocols, ensure the EMR is sepsis friendly, and they identify or create or modify workflows. We report our SEP1 data every month at this meeting. We review how we compare to other hospitals in our system and at the state and national levels. And we discuss our successes and our challenges related to the SEP1 bundle. If you're just starting out, you may even want to summarize some of the specific reasons for fallout. This, according to the SEP1 bundle, because it can help identify trends. Our current goals at our organization are improving the SEP1 compliance and reducing sepsis-related mortality and readmissions. From the steering committee, we developed 3 work groups that perform the actionable items, and they focus on the ED, the ICU, and our sepsis unit, which is a med-surg unit. This helps keep the steering committee just that, a steering committee. It allows the work groups to focus on actionable items relative to their specific area. For example, the ED work group focuses on SEP1 bundles and their shock cases. The ICU work group focuses on SEP1 as it pertains to the ICU and mortality cases for their septic shock cases. And the sepsis unit work group focuses on inpatient code sepsis cases and readmissions. The work groups also have ad hoc members such as case management, palliative care, et cetera, for situational issues or projects. Our sepsis steering committee reports up to our system sepsis committee at Henry Ford, and the work groups at Jackson report to our local Jackson sepsis steering committee. I think if you're starting out, the development of a sepsis steering committee is a place to begin, and I would suggest that you focus on the SEP1 bundle and identifying your workflows surrounding sepsis, and maybe perform a gap analysis to see where you're at and compare that with what's happening with the SEP1 bundle. Number 2, engagement of our key partners. It was especially important in the beginning, and it continues to be, that we have the right people at the table when making decisions about sepsis care. In addition to the leaders and specialties mentioned in our sepsis committee, it's important to involve the clinical staff doing the work. We do not want to create workflows that do not involve our bedside staff. If you're new to this journey, I highly suggest including your bedside staff or at least a representative on your sepsis committee. I also suggest involving your bedside staff, be it providers, nurses, lab, pharmacy, when you are reviewing your EMR and your policies and your workflows that surround sepsis. For us, the code sepsis process, which included our nurse-driven protocol and the sepsis narrator, are notable examples of that. That required engagement from our local staff, since they are the ones calling that code sepsis and using that specific tool. Number 3, specific roles and expectations of our leaders. The sepsis coordinator coordinates the program, ensuring that the policies, the protocols, and the EMR tools are in place that support the care we provide. She co-leads our sepsis steering committee, provides education, partners with the physician champion, educates the community and the staff, and acts as an essential point person for the program. The physician champion for sepsis acts in partnership with the coordinator on all those activities and works to ensure that the providers understand the data and support the changes that impact our providers. Our physician leaders review cases and engage the physicians with what's done well and/or opportunities that were identified. The other leaders are responsible for taking back to their staff what's learned in the sepsis, our system sepsis meeting and our local sepsis meeting. For the work groups, each leader is a nursing manager of that specific area, along with the physician champion for that area. Additionally, the leaders are responsible for follow-up on the fallouts from the SEP1 bundle. Number 4, goal setting. Next slide, please. We set goals at the system level for our SEP1 compliance. We base this on the data that we collect each month for our sepsis patients for the CMS measure. At the end of 22, we at Jackson worked with our system sepsis program leaders and set mortality goals for our hospital for 2023. And we're getting ready to set those goals for 2024. At the same time, our work group set their goals as well. This is an example of a dashboard for our med-surg, our sepsis unit work group. The numbers are fictional, but it gives you an idea of what this work group looks at every month when it meets, and also reports their progress and or barriers back to our sepsis steering committee. So this work group, as I mentioned, was looking at those readmissions. They may also look at other things. For example, they're looking at length of stay and the volumes on that sepsis unit. Number 5, monitoring progress. As I mentioned, we monitor our sepsis data monthly. We provide real-time feedback as much as possible to our providers, including our residents, our nurses, our lab, pharmacy, because it's easier to discuss those cases with staff when they kind of remember that patient. It's a little bit harder to do 3 months back. We also celebrate successes and give that feedback. I think sometimes that's equally as important as talking about the opportunities for improvement. Number 6, revising goals. Very simply, we revise goals when necessary. We don't continue to monitor things for endless periods just for monitoring's sake. And lastly, challenges and successes. Challenges, step 1 is complicated. Sepsis is complicated. I have an exclamation point over that in my notes. Step 1 gives us a lot of specifics, but or it gives us a lot of data, but not a lot of specifics. So it takes resources to really delve into those cases to find the root causes for those fallouts. Another challenge is that there's competing priorities for all of us. There's so much work to do around sepsis, but it's not the only thing. With the pandemic and staffing shortages and turnover and burnout and all the things, it's important to keep projects and goals manageable so that progress can continue to be made and our leaders and our staff aren't overwhelmed. And then successes, I have to say, hands down, our most significant success is the engagement of our staff. Our bedside clinical staff, physicians, nurses, all the clinical folks are very dedicated at our organization to sepsis. They're proud of the work we do around it. We have a sepsis unit with staff that is dedicated to providing care to these patients. And we also have leadership that really support our staff in the work that they do around sepsis. I'd like to end by saying that we at Jackson did not do one big thing. We did a million, continue to do a million small things. And I think that means that it's doable for everybody then. You just have to start.
So today I'm going to share with you Northwell Health sepsis journey, which began in 2008 and continues today. I will share how our journey pertains to the 2nd and 3rd CDC sepsis hospital core elements following this agenda. Next, please. Northwell Health is the largest healthcare provider in New York State, consisting of 21 hospitals and 850 ambulatory facilities. Next, please. In 2008, Northwell Health prioritized sepsis as a system-wide initiative, and that continues to this day. We use the collaborative model as our structure and implemented PDSA as our primary improvement strategy. The collaborative relies on the collective knowledge of its participants, builds on the sharing of progress and experiences of all facilities. The collaborative is supported by an internal faculty of subject matter experts providing evidence-based updates and assisting in setting the educational agenda. The structure is both top-down and bottom-up. Accountability for sepsis care rests with our senior executive sponsors and flows systematically down to the sepsis team. These teams are the boots-on-the-ground heroes at the site. They are the ones doing the process improvement work, based on their individual site needs, and these are based on their specific bundle element data. The bundle element data is presented in a sepsis-specific Tableau dashboard for the entire health system that can be sorted by site and date. The information collected and outcomes are reported up to the sepsis leadership and ultimately to the board. To support this effort, the sepsis teams are provided with a dedicated sepsis platform staffed with analytics specialists, clinical experts, and a dedicated improvement sciences team. All this support provides a strong framework for taking action to achieve, sustain, and disseminate information on breakthrough improvements through monthly meetings and quarterly sepsis educational sessions. Next, please. Northwell feels that accountability is more than just being responsible for sepsis care, but it is important to feel a sense of ownership. Some of our supports for accountability and ownership include an organizational scorecard, setting of organizational goals, monitoring our performance and data, our performance data and outcome data using our dedicated data abstraction tool, which provides consistency and accuracy to all the abstractors. Having site-specific nursing and medicine sepsis leaders and sepsis champion programs. The initiative is focused on the ED. That is where 75 to 80% of Northwell cases present, and then we have expanded the initiative to the inpatient unit. Next, please. The importance of multi-professional expertise cannot be stressed enough. All hospital sites have active sepsis teams that meet at least monthly and consist of physicians, nurses, data analytics, and IT specialists. They include members from the pharmacy and the lab who attend on an ad hoc basis. Teams share their improvement projects at the organizational level via monthly collaborative calls that allows us all to communicate our best practices. They can be tweaked and utilized for the specific needs of other teams depending on their size. I have enumerated other examples which are on this slide. Next, please. So what have some of our successes and challenges been over the years? Successes. The collaborative model and its structure have provided us with a foundation for substantive improvement in care processes, utilizing a focus on bundle elements, which we then use process improvement in real time and share that information across all our sites. Dedicated and educated clinical abstractors input data via our specialized tool into our sepsis database, which populates into our sepsis dashboard. This assures accuracy and decreases bias and error in our data, ultimately making it transparent throughout the entire organization. Outcome measures such as mortality and equity are also monitored for trends and further analysis via this Tableau website. Northwell's participation in state, national, and international sepsis initiatives helps to keep us up to date with the latest developments. For example, we have active participation in the New York State Sepsis Advisory Council. Ipsos, a national pediatric sepsis organization, is also another one of the organizations that we belong to. And the End Sepsis campaign, which is an international organization which Northwell has been a proud participant in since its inception in 2012. Of course, like everyone else, we're certainly not perfect. We can all agree that COVID has a significant role in derailing many of our normal day-to-day healthcare workflows. Just like Dr. Drolet mentioned, we are still regrouping and revising our sepsis initiative after the COVID interruption. Loss of experienced staff that held great sepsis knowledge and institutional sepsis history is one of the major losses. Hiring, onboarding, and educating new staff is a continuous struggle. We will try to work with HR to specifically include sepsis activities in our team member appraisals. Our aim is to increase critical care and assure multidiscipline representation on the site sepsis teams, but that does remain a challenge today. Next slide. In summary, it has taken our organization over a decade to establish a system to decrease sepsis mortality. This slide represents all our work from our baseline data collection year of 2008 to the present. We reduced sepsis, severe sepsis, and septic shock non-risk adjusted mortality by 50%, from 32% to 16% in 5 years, and have continued decreasing until 2019, when we reached our stretch goal of 10% mortality. That represented a 66% decrease from 2008 to 2019. I will draw your attention to the red lines on the graph. This reveals the disruption COVID caused between 2020 and mid-2021. Since Q3 of 2021, we appear to be heading in the right direction. We've achieved a 12% mortality in mid-2023. Sepsis awareness, early identification, and prompt treatment continue to be our focus.
Yeah, I represent Corewell Health West, and we're a group of 11 hospitals. We're kind of centered around a large institution in Grand Rapids, our Butterworth site, that has 850 inpatient beds and over 100,000 ER visits per year. And that's where we began our work in sepsis and then spread it to the rest of the system. We were somewhat stuck in 2015 through 2018. We were wanting to improve our mortality, but we were stagnant at 27%. We had teams working around the edges, but we struggled with variation in process. There was mixed reviews of the evidence and guidelines, and it was time for a reinvestment. Next slide. So our leadership at that time decided that fiscal year of 2019 was going to be a focus on sepsis care, and that would be one of our strategic quality goals. And they tasked the acute care service line with ownership of this goal. And that was a physician leader and an operational leader that together oversaw our ER, our hospitalists, our acute care surgeons, and collaborated with our ICU to take this goal and make it happen for our hospital. With their support, we created a business case and decided it was time to hire a sepsis coordinator. And we found an excellent colleague, an RN sepsis improvement specialist that joined our team. And it's cut off slightly on my screen, but we set a goal, number 3, was that we needed to reduce sepsis by 20%, reduce the mortality by 20% in that first year. So we tried to push ourselves. Next slide. This is some of the outline of our expert improvement team that we established at that time. We had the improvement specialist, full-time equivalent at that time. And then we recruited an ICU and ER medical director that already had a significant kind of 0.5 FTE protected for quality initiatives such as this. Those two were going to be the chairs of the work, accountable to the outcomes, and we're going to lead the team as we move forward with our ambitious goal. You can see the next 2 lines, light blue and green, all the critical professionals that we had to have part of our group if we were going to make a difference. Pharmacists that understood the process of getting an antibiotic to the bedside, what barriers there are, timeliness, antibiotic stewardship expertise that they brought, hospitalists and residency team members that joined us, nursing leadership, as well as bedside RNs. And we needed our team to support that they could badge in and they could get paid for their time working on our work group. You can't do this just with volunteer hours if you're going to make a big difference. And then finally, the light green row, just the critical support of infrastructure around our system. The leaders found team members in these groups and told them that this is a priority now. You need to take this and put it at the top of your list. There are some things that we are going to accept, move down, because now sepsis is a goal for you. And their engagement was so critical as we move forward. We even leveraged like a rapid improvement event. And sometimes you can do it over a few hours. We did it over a couple of days, and we paid for everyone to be there. They needed full dedication of their intellectual creativity to improve our work and achieve the outcome we were going for. Next slide. This is just an example of one of the outcomes of that rapid improvement event. Initially, we produced it on a 1-page guideline that nursing, provider, pharmacy, everyone could look at in the moment and make sure that their role was well defined and they knew how to win, how to get it done for that patient. We brought together, you can see the green boxes are kind of examples of that multi-specialty expertise. We agreed as a physician leadership team, what do we define as code sepsis? Who meets that criteria? How are we going to find them even at triage? We then said, what is our goal? What are we going to do at the 15-minute mark, the 60-minute mark, the 90-minute mark? And then we even structured that admission handoff. How do we make sure that the right pieces of information are discussed every time so that the pedal stays to the metal on these patients? We don't let up as they get up to the floor. The yellow and purple boxes just show that kind of multi-professional expertise coming into this work. Nursing roles, pharmacy roles, reassessments, and even informatics. Purple boxes, just examples of how, while we outlined this on paper, we immediately started the process of building it into the EHR, wrapping our order set around it, creating a sidebar that turned green every time one of your goals was achieved. Just examples of the output. Next slide. And when you have this major effort and you are making a difference, you want to know if you're winning or not. You want to know, does it make a difference? What you see here is just an example of the baseline effort, which is CMS fallout reviews. Necessary and important, but the data is not timely. We all know that. When you add a sepsis improvement specialist, we built in a weekly cadence where we could review every single case that came in that prior week, both the ER cases and the hospital identified cases. Our coordinator would sit down with me, we'd go over in detail, and the major benefit was twofold. One, that timely feedback. Here's the opportunity. Here's the tool in the EHR you didn't know about that you could leverage next time, but also the wins, knowing all the success that was out there that you don't see when you only look at fallouts. So we sent thank you letters. We put out sepsis champions for the month and a variety of positive feedback to help change that culture. Next slide. And then from a sustainability standpoint, we needed that big picture data. And I heard Dr. Friedman talk about Tableau as well. This is where we can get an automated data pull from the EHR to track kind of the 3,000-foot view. How are our teams doing month to month, year to year, and where do we need to emphasize, efforts to change, recognize a trend before when we still have an opportunity to intervene, and then also, can we drill down on this? We made it so that you can get all the way down to the MRN or to the provider attribution. So I can search one of my ER providers and give them, hey, this is your 8 cases from the last year. If you want to deep dive them, great, but just pay attention to this. I appreciate it. And here's your own review. Next slide. We've obviously had success. We've been proud of what we've accomplished with this collaborative effort. And this is just the outcome. We started in Grand Rapids and we spread it to the 11 hospitals around West Michigan that we were responsible for. And our mortality for ED sepsis outcomes there across the entire group drops significantly, as you can see. Last slide. So with success, you spread it. Obviously, we brought it to our other hospitals. We received a little award for the work, and we're proud that mortality is stabilized at about 10%. But you can also lose some of the best people when they demonstrate what they're capable of. And we did get our sepsis collaboration, our specialists got reassigned to another team because the hospital had other priorities. All of a sudden, we were now in a place where we could maintain and lost that resource. And that's acceptable. We all live in environments of limited resource. And so we have to navigate through that. And you can see what we do now. We educate new team members as they come on board. We review our clinical pathways on a regular cadence. We adjust our EHR tools to align with the changing CMS core measure. And then we give the feedback when we have it. The timeliness of these new core elements struck me because it's about time for Cornwall West to engage and invest again. And I see opportunity within the outline that Hallie presented for us today. So excited to see where we go next. And thanks for hearing from our example.